Start recording.
Is this PowerPoint going to be posted as well?
Say it one more time.
Is this PowerPoint going to be posted as well?
Yes, so I will share both the PowerPoint that I go over and also I'm going to do 2 activities with you and I'll share those as well.
Thank you.
Of course. So let's go ahead and start this. So we have a few practice questions. I've been able to meet with quite a few of you and do kind of one-on-one practice questions. These are for the content for the week, and then also I just want to take the opportunity to kind of go through the question format and kind of talk about that and talk about rationales in general. So we have an assisted personnel, so basically an aide, reports to the nurse that a client who is 3 days post-op following an abdominal hysterectomy has a dressing that's saturated with blood. Which of the following tasks should the nurse delegate to the AP? What do you guys think? I can't see the Blackboard when I have the slide show up. So you can say on your microphone if you want. Which task can an aide do? Are you guys typing? I can't see.
Can she check for vitals?
Yes. So correct. So it's obtain vital signs. And the reason why, so changing the dressing, that's a nursing task. So whenever we change the dressing, we need to assess the wound. So we can't have aides doing assessment and we can't have aides doing education. Those are RN duties. So obtain vital signs is appropriate. Palpate, that's an assessment, as well as observing the incision site. Observe is just another way of saying assess, so they can't do that. Okay, we have a nurse in a clinic caring for a client requiring a hysterectomy who states she has decided to delay having the surgery for several months. Which of the following statements should the nurse make? So this is going to be a really standard question. Is you're going to have a setup in the question, and then what are we going to say? So what do you guys think we should say? I can see now if you type, I fixed it. Tiffany thinks C. And that's exactly right. So whenever we have a setup like this, what they're looking for you to do is assess further. So if there's an option for you to say something to find out more about what's going on, that's what you want to go with. So we don't want to say, oh, the surgery is very easy. What if something goes wrong in their surgery? We don't know that. Yes, normally it is, but that might not be what made her delay it, right? We don't know why she delayed it. Most women don't have any problems. Again, maybe she's not worried about her recovery, so we don't want to assume that we know why she delayed it. We want to find out more, and then we can talk to her about that. Some of these statements might be appropriate after we talk to her. And then she, we don't really share what happened to her family members. She doesn't care. So we would do C. Can you elaborate on your reasons for delaying the surgery? Okay, this is a little bit of a review last chapter as well. A nurse is assessing a client who's post-op following a vaginal hysterectomy. Which of the following findings is a manifestation of deep vein thrombosis? Exactly.
Would it be D?
It's going to be D. Mm-hmm. Yep, it's going to be D. So coolness of the leg or legs is not what we would expect. We would expect warmth in that leg. Decreased pedal pulses isn't related to DVT. We wouldn't expect that finding. Pain in the ankle and the foot is incorrect. We would expect pain in the calf. And then unilateral leg edema is one of our hallmark signs, right, of a DVT in the leg. And then what puts her at risk for having a DVT? Any ideas? PE. That's another risk. Why is she at risk for clots?
Because the question states so.
The question does not state that she's at risk. I'm asking physiologically why she would be at risk for having something like a DVT. So good guess, Michelle. The reason is because she had surgery. Hysterectomy, yep. Lack of physical activity, exactly. So we have a patient that has just had a surgery that puts them at risk for having clots. A nurse is presenting
Do all
educational
surgeries
material.
put the patient
sorry?
at risk for clots?
Yes.
Thank you.
A nurse is presenting educational materials for a group of middle-aged clients about menopausal hormone therapy following total hysterectomy. Which of the following information should the nurse include in the information? In the teaching. It's kind of repetitive. Ooh. There we go. Sorry. I skipped the part. Yeah, it's D. We don't want them to take it at different times of the day. This is a medication that we want to take the same time every day. We don't want them taking extra doses if they forgot to take it. Really, for most medications, that's not what we're gonna have them do. It doesn't prevent them from having a cerebral hemorrhage. We actually have an increased risk for stroke when we're on HRT or hormone replacement therapy. But it does help prevent osteoporotic fractures. Okay, a nurse is assessing a client who's being admitted from the PACU following an abdominal hysterectomy. Which of the following assessments is the nurse's priority? Right, it's B. So this is a really common theme in your questions is prioritization, right? So if you and I met together, we likely talked about kind of some strategies for prioritization. So we want to think airway, breathing, circulation. If those are all fine, yeah, Brandon, ABC is exactly. What can kill us first? Yes. If there's a choice of 4 choices and they all sound good, which one, if you didn't do it, would be the worst? So yeah, exactly, Tiffany. Like what's going to kill the patient first? Is there something that's a safety hazard that if you don't correct it, they will be harmed or killed? Okay. So in this one, all of these are appropriate assessments. We do want to know what's going on with their abdominal dressing. We want to make sure that there's not copious amounts of bleeding. That's appropriate to check. Oxygen saturation is going to be the answer, because the ABCs, if we could only check one thing in the PACU, if we were just a terrible nurse and we were only going to do one assessment and we're not going to check the other things, it's only important to check the oxygen, because if that is bad, then our patient can die, right? Urinary output, we'll check in the PACU for sure. Pain level, this is kind of throws people off sometimes when pain level is a choice, because we want to be good nurses and we want to get our patients what they want and make them comfortable. But pain is a lesser priority. Okay. A nurse is caring for a adult female client reports that her menstrual periods have become irregular and she has been having hot flashes. The nurse should expect the client to have which of the following manifestations associated with early menopause? Yep. Correct. So we would expect the patient to report dryness because of that decrease in estrogen. Urinary retention, we wouldn't really expect retention. We are concerned about incontinence during menopause because of the loss of tone of the bladder and the urethra. Decreased blood pressure, we wouldn't expect that. We'd honestly expect an increase in blood pressure. We see more hypertension happening as we age. An elevation in body temperature might kind of throw somebody off, thinking that, oh, okay, hot flashes, maybe she's more hot, right? But it's not associated with your body temperature. It's just the body's response. Alrighty, so that's our questions. Hopefully that kind of helped with questions in general. Again, I know the people that I've met with, we talked a little bit about how to narrow down and how to think about prioritization. Do you guys have any questions about just questions, how to approach questions in general?
Are these examples of questions that will be asked during the test?
They're similar, yeah. So I pulled those off of ATI. Those are ATI questions.
Do we have more questions we can go through?
I have something different that I actually want to do. I'm going to share my screen in just 1 second. Okay, have you guys seen system disorder templates at all? Or is it something new for you? You've seen them? Okay, so I
Yeah,
thought,
we do those in Sims.
you did them in SEM. Have you done one for osteoporosis and menopause? No? Okay. So let's do it together. Let's talk through it, but don't worry about taking notes because I have one that I already did that I can share with you. Okay, so, but let's kind of talk through the disease process to review our content, okay? Okay, so let's go to, and have this so I can see my notes. Hold on really quick, let me see if I can share it differently. Okay, that should fix that. No. All right, that's gonna be fussy with me. Okay, so let's do menopause first. Menopause, can't spell. There we go. So what is different in our patients' health when they hit menopause? What's like the main issue that we see? Hormone levels, yes, exactly. So, so our diagnosis is going to be menopause. Our pathophysiology, what is causing the problems? Estrogen deficiency, right? Change in hormones. Okay, what are some risk factors that we have for menopause? Age, yep. So Samaya, flushing is going to be one of the symptoms that we might notice. Yeah, we have to be female, right? Or at least assigned female at birth. So female. And then we're going to be looking at the age from 40 to 58-ish, right? We can have it a little bit earlier and premenopause type stuff. Diet, not really. Hysterectomy, yeah, that's correct, Samaya. So that is induced menopause. So hysterectomy. That's pretty much it, right? It's going to happen to every female as they age. So it's not necessarily a disease process as much as it is an aging process in the body. Okay, so Samaya already guessed for us hot flashes and night sweats. Dryness, yep. What other symptoms would you think that they would tell us about? What about incontinence? Being anxious? Yeah, for sure, Brandon. That's one of the psychosocial things, is just maybe being a little bit nervous about what everything means. Their body's changing. So a big one that we're going to notice is that they don't back pain. Possibly. Maybe if they've got some osteoporosis stuff going on, they could have some back pain. But the biggest thing that we're going to see is they will not menstruate anymore. So that's going to be on our hallmark sign that we're in menopause, is that the periods become irregular and then eventually cease, right? Okay. What kind of laboratory tests do you think? Let's pretend we're at the Women's Health Clinic, our patient's here, and she's concerned she's in menopause. What are some things that we might check in a laboratory test? Estrogen, you could. So on our labs, we would expect decreased estrogen levels. Iron's prudent to check. I don't know that it would be necessarily correlated. I really start to kind of worry about iron when we have the abnormal uterine bleeding and we're losing a lot of blood. What else might we check? Calcium, yeah, definitely, that's a good one. LH, luteinizing hormone. So actually so calcium, I'm gonna add that one. Hydration. You could, usually not in outpatient. We won't be too concerned about hydration unless for some reason the patient is not eating and drinking or something like that. So what we'll actually check, let me add calcium, that's a good one. is the FSH, or the follicle stimulating hormone. And when we see that is less than 30, constantly elevated, and also coupled with the cessation of menses, then we can diagnose menopause. Another big one that we want to check is going to be our cardiovascular labs, because as we hit menopause, we have an increased risk of cardiovascular complications, right? So we want to check our, what am I trying to think of? Cholesterol. So the LDL and the HDL. Okay, so basically not a lot else, because our patient isn't really sick, right? This is a normal process of aging, so we really don't need to get a bunch of labs. If we wanted to start them on hormone replacement therapy, we might check the levels so that we know what we're working with. Might also check thyroid at this point. Okay, what else? Diagnostic procedures. Again, there's not really any testing that we're going to do, maybe our labs. So for this, I just put that they're going to tell us that they don't menstruate anymore. And we want to see that for a full year. Any safety considerations? And for safety considerations, I'm not really looking for complications as much as like serious safety problems. Hormone therapy, yeah, Samaya. So with the hormone replacement therapy, the biggest thing that we're going to worry about is the increased risk of blood clots. Right. And then one other thing that's related to our estrogen is we start to see osteoporosis symptoms. So we have an increased fracture rate. So we're concerned about fractures because of bone density decreasing, and we're concerned that we could have blood clots. Those I felt like were the biggest safety issues, right? So for nursing care, what would you think are some things that we could do? Some nursing interventions.
Where do you pull this information from?
On text? What do you mean?
The Lewis book?
Uh-huh.
What pages would we be able to find information like this?
What do you, in reference to what?
Everything.
Like the entire.
Correct.
Huh? The entire thing is from the book. It's from Lewis. It's the pages that we were assigned for module 11. Okay, so for nursing care, any ideas about nursing interventions that we do for patients? Yep, exactly, Brandon. That's really about it. So we can provide education, both on what's the bodily processes that are going on, treatment options is kind of it, and then just provide reassurance. Because like we said earlier, they're probably feeling a little bit of anxiety about their body changing because they don't know what's going on. Maybe they don't know if there's any treatments that they can take. So we'll provide them reassurance, and then we will provide them education. There's really not any other true nursing interventions because, like I said, they're not really sick. Okay, therapeutic procedures. For this, I'll just write what I put. So I put hormonal or non-hormonal therapy. There really isn't any other, there's no surgery, there's no other kind of procedures really that we look at. So what about medications? Estrogen. So we can do hormone replacement therapy. Estradiol. Estradiol. Do you guys remember anything else from the reading besides hormone replacement therapy drugs that we can give? Yeah, Brandon. So there's herbal therapy, and people do take that. Research does not back that up. It doesn't support it, that it's truly helpful, but I guess anecdotally, if people want to take it, we just need to make sure that whatever they want to take does not interfere with any prescription medications or other supplements that they're taking. So good. We got supplements. Patients also can take SSRIs, selective serotonin reuptake inhibitors, and the reason that sometimes patients take that is it reduces hot flashes. We also have clonidine or gabapentin. So clonidine normally I've given for decreasing blood pressure, but in this instance it can help with the vasomotor symptoms like the hot flashes, flushing, night sweats, that type of thing. And gabapentin is also a anti-seizure medication, but it can also help with those symptoms. So kind of off-label almost use of those drugs. Yeah, exactly, Jay. That's good. So calcium, vitamin D. The other major one that we could see is the SERMs, and that's the medications that block estrogen. So what they do is they sit in estrogen receptors, and so they can actually act as estrogen on different areas of the body, and it can block estrogen. So in patients maybe that were concerned about a hormonal breast cancer, they might be prescribed something like a SERM. Okay, that's all I had for that. So for our education, we kind of already talked about, we would teach about possible, I'm sorry?
Question?
Yeah.
So I'm in the section of menopause in the book, and under medications, I'm not seeing all the ones that we listed here. Would you be able to tell me what pages I can look at?
Yeah, let's finish the template and then I'll pull up the chapter, okay?
Thank you.
So possible treatment options is something we might talk about. What else would we want to teach them about? SYCH. I don't know what that is. Oh, psych maybe?
Like a psychology and things.
Yeah, anxiety maybe.
Yeah.
Yeah. Pericare? Could be. As we hit menopause, we start to have risk of cardiovascular disease, right? So we want to talk about how to prevent or reduce the risk of cardiovascular disease. And then we're also concerned about preventing or reducing the effects of osteoporosis. So within there, diet, all that. We'll talk more about that when we get to the osteoporosis one, but both of those. As far as interprofessional care, we're going to use our provider to really diagnose the patient. Nutrition. We can support the patient, health plan, diet, etc. Okay. We talk about safety considerations. What about complications? What is the result of having decreased estrogen levels, decreased hormone levels in the body? Stress. Yeah, I'm gonna, yep, osteoporosis. So I'll just put increased fracture radian. For stress, I'm gonna take that as stress incontinence. So we can see that. Stress or urge incontinence. Blood clot, so MI, yeah. I'll just put cardiovascular disease to cover that, but yeah, Brendan, that's true. We talked about another point of stress is just emotional lability. So labile emotions are ones that change, basically mood swings. We can see, disturbances in sleep pattern. Sexual health, yeah, so who knows what this means? What is dyspareunia? Good guess, Tiffany. It actually means it's discomfortable. Yeah, uncomfortable, not discomfortable. Exactly. So pain during sex. Yeah, it can be from dryness. Samaria. What else? We have decreased collagen throughout the body. Breast tissue changes. I think those are the ones I had. Okay. So that's basically, you can do these for any of the disease processes that we go through. I think it really helps to kind of create one, and then you have it for studying. And like I said, I already made these. Don't feel like you have to write this down. I will send these out. Okay, so let's see. Jasper had a question about the book. So let me pull up the text. Okay, let me share the screen. Okay, so basically you've got perimenopause, postmenopause. This is where I pulled all my symptoms from. Manifestations of estrogen deficiency. We talked about a lot of these. Clinical manifestations. So drug therapy, we have hormone replacement therapy with estrogen with or without progesterone. Non-hormonal therapy, all the medications that I talked about are right here. So SSRIs, we have clonidine, which like I said is an antihypertensive drug. Neurontin, selective estrogen receptor modulators, such as Evista, also manage symptoms. They have the benefit of estrogen without the negative effects of hormone replacement therapy. Does that answer your question, Jasper?
Perfect. Thank you so much.
Yeah, no problem. Okay, so let's go to all right. Let's do osteoporosis. Hi, my mom. Sorry. Daughters. I'll put you in there. Okay. So our alteration is osteoporosis. What is happening? What's the pathophysiology that's happening in our client? Soft bones, yeah. Exactly, Tiffany. Yep. So we have chronic. It's a chronic problem, right? So we talked about acute and chronic problems. So chronic problems, we can manage the symptoms. Acute problems, we can fix. So we can't fix osteoporosis, but we can try to manage the symptoms. Okay. There's a lot of risk factors. I put all of them on mine, but let's see if we can come up with just some for our discussion. Who knows a risk factor for osteoporosis? Mm-hmm. What about gender? Mm-hmm. Menopause? Yep, exactly. So women are going to be at a higher risk than men. Chemotherapy, yeah. So long-term use of drugs. So there's going to be exactly medications. So some medications act on the bone tissue and can break it down more over time. So the biggest one you're probably going to see is steroids, long-term use of steroids, corticosteroids. So yeah, malnutrition is a good one too. But yeah, chemotherapy too. And And then what races are more susceptible to osteoporosis? You'll see more frequently. Mm-hmm. Definitely Caucasian. Caucasian. There's one other one. Exactly. Yep. Asian American. Or just Asian. They start to get really tiny, so let's see. So pregnancy and breastfeeding is another thing that decreases our bone mass over time. So women that go through pregnancy and breastfeeding have to come up with a lot of calcium to create a new human, right? And to create milk for breastfeeding. So hopefully we've supplemented that in our diet, but some of it does depreciate as well. Smoking is another big one. Can contribute to bone loss. Sedentary lifestyle, excess alcohol. So usually greater than about 2 drinks a day is going to be too much for pretty much any disease process that we're going to talk about. If you're over 2 drinks a day, it's usually going to increase your risks. Within men, low testosterone. And then the same thing for the medication. So corticosteroids, thyroid replacement, heparin, long-acting sedatives, anti-seizure drugs can all contribute to our risk. And then if they have a family history of osteoporosis, they're also going to be at increased risk. Family history. Okay. So what are some laboratory tests? Our patient, we're at family practice clinic this time. Our patient came in and they're concerned maybe they have osteoporosis. Yep. So we might check that, but it can be normal. So a lot of times our calcium, Somebody's got it, calcium, phosphorus, can be normal. Vitamin D is a good one to check. Vitamin D, because if that's low, we can supplement it, right? And we need vitamin D in order to absorb calcium. So that's why we talk about vitamin D when we talk about this process. So skipping ahead to diagnostic procedures, we were talking about bone density. What is the name of the gold standard test for osteoporosis that you will see ordered? And Brandon, I appreciate you throwing out some idea. Bone density scan, yes. It's called a DEXA scan. You'll see that. There's also what's called QUS, qualitative ultrasound scan. The DEXA scan actually uses X-ray to check, and then the ultrasound uses ultrasound waves to check. So the DEXA scan is more accurate. Let's see. And then normal X-ray, your standard run-of-the-mill X-ray that you're getting, it's not caught on X-rays because it's not visible on this type of X-ray until 25 to 40% of the calcium is missing from the bone. So that's quite a bit. So it's definitely not a good screening tool. The DEXA scan is much better. Okay, So expected findings, I'm just gonna fill in, I won't make you guess. I put for this, so low bone mineral density scan, right? We would expect that they would have this on the scan. And the way it's measured is a T-score. And we want to see a T-score less than 2.5 for osteoporosis. Negative 2.5, sorry. And a normal T-score is going to be -1 to 1. Okay. We might also see something like fractures, especially like a compression, fractures in the back, weakness, yeah. Symptoms like that. Okay. Safety considerations. Again, the biggest risk that we have is risk for fracture. It's really the worst kind of thing that can happen to you. If you think about worst case scenario safety things. And then the other one I put on here, so this class of medications, it has a rare serious side effect of causing osteonecrosis of the jaw. And so osteonecrosis, if we break the word up, osteo is bone, necrosis is death, bone death in the jaw. So I thought that it qualified for safety consideration, and I put that on my thing as well. So just for osteonecrosis, the jaw. Okay. What about nursing care? Or some nursing interventions that we might do? We're taking care of this patient on the floor. What do we think we might do? Good, good, good. Yep. So nutrition. There's one other education that we might add on. Brandon kind of hit it. Exercise. All right. So we want them to be active. We want nutrition's going to be huge, right? And then what else do we want to do? Focus our nursing care plan on. Exactly. So we want to prevent falls and maintain safety. Yep, exactly. Prevent falls. You don't want these people falling down. They're going to break their hip. And we got more problems. Okay, so for procedures, we do have 2 procedures that we can do. There is vertebroplasty. And that is where they inject bone cement. And that's going to be in between the vertebral bodies. And so they inject the bone cement that helps prop them up and support the spine and decrease the patient's pain. Very similar procedure, kyphoplasty. They're going to do the same thing. They're going to inject bone cement, but they're going to insert a balloon into the space between the vertebra and open it up and then inject the bone cement. So one, they just go ahead, stick it in, inject the bone cement. The kyphoplasty, they're going to prop it open and then inject it to give it more space and hopefully kind of place it back to where maybe it once was. Can you do that? For spinal stenosis. Degenerative disease, we usually see them during fusions. There might be some bone cement in there that they're placing, but usually that's going to be the fusion where they're putting extra hardware and stuff. Okay, so medications. What kind of medications do you think these patients? It's 9 o'clock. It's time to give them their medications. What are they gonna get? Supplements. Yep. So probably some calcium, vitamin D. What other medications are prescribed for osteoporosis? Calcitonin, possibly. What about this one that we talked about? This medication class. Yeah, exactly. Bisphosphonates. Okay, some other classes, monoclonal antibodies. Raloxifene. Okay. Education. We kind of already talked about this in our nursing care. We're going to promote nutrition and exercise, so we're going to provide teaching on intake of calcium, exercise. We want them to do weight-bearing exercise. And weight-bearing exercise is going to be when the body is working against gravity. So things like swimming are not going to be helpful for osteoporosis. Okay. How about medication? Education, right? Because whenever we give a medication, we're going to explain it to the patient and we're going to let them know what it's for and then major side effects that they're going to watch out for. Pain management, that's a good one. Talk to them about options about that. That's a good idea. What about smoking and alcohol? Okay, if they're a smoker or if they're using alcohol above our limit, we're going to talk to them about stopping that so that they have less risk. Can we do hormone therapy? Yeah, that could definitely play into it. With males with low testosterone, we can replace testosterone. And then depending on what's kind of going on with a woman, we could do the estrogen replacement or the SERM medications. So yeah, that's another one. I'll put that over here. Okay, good. The other major one that you're going to see is for this. Do you remember what we need to tell our patients about taking these medications? Well, let's start with when do they want to take it? At night? Usually they take it in the morning. Thanks for guessing that, Brandon. You're awesome. So we want them to take it 30 minutes before they take any other medications. So kind of easier to do in the morning. Same kind of thing with your thyroid medications. You're going to take them usually at 7 is when they're scheduled. So that way, just because we want them to take it before they take other medications. drinking when eating. And also we don't, I'm going to get to in 1 second, we don't want them to lay down, and at night they're about to lay down. Yeah. So you kind of guessed what else is next. So we want them to take it with a full glass of water, and we want them to stay upright for 30 minutes. So could it be done at night? I suppose it could, but it's just kind of easier in the morning because they haven't had any other medications and they're not fixing to lay down, right? Probably. At least not for 30 minutes. Okay, so that's definitely something that you can see again for osteoporosis, these directions for this medication. You can see on your NCLEX and things like that. So that's the big one. I put our provider is going to order our medications that are appropriate for a patient. I think nutrition can be involved, exercise, we might get PT involved, right? What are some complications of osteoporosis? Breaking bone, yep, that's the big one. Fractures, fragility, yeah. Just having to be more careful overall. Fractures is the big one. Injuries, yep. Really have to be careful with these patients and falls. So kyphosis is another one. Have you guys seen this in your book? This is where the patient starts to become hunched over. And that happens when the vertebral bodies lose their mass and they start to pinch together. It creates that hump. And it's called kyphosis. The medications that they take in general can cause anorexia. Weight loss and gastritis. So because of the gastritis is why we want them to take it with a full cup of water, glass of water. Kind of make it easier on the stomach. Okay. Well, that's pretty much all I had. Like I said, I'll send these out. Anybody have any burning questions before we stop for the night?
These were super helpful. I kind of wish we would have these since the beginning. But thank you.
Yeah, okay. You're welcome. All right, I'm glad it was helpful, guys. We'll see you. While you guys are here, is earlier in the day a possibility, or does everybody have sim and things like that?